So we are live. Yay. All right. Welcome back, everyone. We apologize for that little glitch in getting started, but hopefully it means that those of you that were late to joining the live stream right at 6:30 are now here. So you haven't missed a thing. So with that, I'd like to officially welcome everyone to our community conversation event hosted by the County of Marin and Marin Health and Human Services. I'm Lainey Hendricks. I'm Public Information Officer for the County of Marin, and I will be your moderator for this evening. Tonight's event will discuss COVID-19 in Marin, the shelter-in-place order, and begin to explore what might be next for all of our residents and businesses. But before I do that, I want to remind you that you can find the latest information on COVID-19 in Marin County by visiting our website, which is marinhhs.org/coronavirus for information in English, and marinhhs.org/coronavirus-es for information in Spanish. On that webpage, you can also sign up to receive our daily status updates, which contain an overview of confirmed case data and other updates about Marin's response to the COVID-19 pandemic. Simply click on the subscribe button when visiting the coronavirus website, or to receive updates by text message, you can text the phrase Marin COVID to 468-311 to receive those daily status updates by text message. Well, it's now been 1 month. 1 month has passed since the Bay Area implemented a regional stay-at-home order in response to the COVID-19 pandemic. Residents and businesses alike have made major changes to minimize the spread of the virus, and yet the virus still exists in our community, and hospital surge remains a possibility. When might the shelter in place be lifted? Well, that's a question on the minds of many this evening. And to walk us through this conversation are Marin's top public health experts, who I'd like to introduce you to now. First, Dr. Matt Willis, Marin's public health officer, who I would like to also welcome back after a successful recovery from a very trying case of COVID-19. Thank you, Dr. Willis, for sharing your experience with us so we can better understand the severity of the virus that many are experiencing here in Marin. I'd also like to welcome back again this week Dr. Lisa Santora, Marin's Deputy Public Health Officer. Ooh, that doesn't roll off the tongue well, does it? Dr. Santora has been instrumental in our hospital surge planning, as well as working alongside our senior residential facilities and related support efforts. And might I add, did a pretty good job leading the team while Dr. Willis was recovering from COVID-19. This might be a stretch. No, it's not. Marin is really blessed to have such a strong pair of experts leading our public health initiatives. So with that, I'd like to start off. Dr. Lisa, can you give us an overview of what the COVID-19 crisis is like in Marin, and perhaps a situational update on cases?
Great. Thank you, Lainey. And good evening, everyone. Thank you for joining us tonight. We have today 199 confirmed cases of coronavirus or COVID-19. And importantly, we now can confirm that we have 140 recovered cases. And we are learning that because we have public health nurses reaching out to people who have been diagnosed with COVID-19 to check up on them and see their status. We have now very excitedly have completed more than 2,800 tests. And as you've been hearing on the news, testing is critical for us on the road to recovery. Notably, only 7% of those tests have been positive, and we're testing mostly symptomatic individuals. So I think it's important to remember that although COVID-19 continues in our environment, affecting the respiratory health of many, we still have the flu, we have other viruses and other colds, strep, everything above that is still affecting our community. But we are now deeply committed in prioritizing COVID-19 testing because it is the part of our road to recovery. We have had 38 total hospitalizations, but only 3 are currently hospitalized, which is important as we continue to talk about preparing for medical surge. And as of today, we still only have had 10 deaths, which is still a sad part of the reality of COVID-19, is that unfortunately it can impact older adults especially, and of our deaths, all have been over the age of 65. And that just leads to an area of focus for us. You've seen in the news that the state has released information around skilled nursing facilities that have outbreaks But we also track outbreaks in other facilities and other congregate living in Marin County. And we have 47 cases among residents and staff in congregate living facilities. And we have outbreaks confirmed in 10 facilities. That's an update, a status update for where we are now. Thank you.
All right. Thank you for that news. Dr. Willis, given the status of COVID-19 in Marin, and now that you're back focusing on that effort that both you and Dr. Lisa were a part of in terms of setting that regional shelter-in-place order with our regional Bay Area partners, is that still a priority for you? Tell me a little bit, what are your priorities now that you're back in at the helm and leading our public health efforts?
Yeah, I mean, I would say I'm transitioning. Lisa and I are sharing the tiller together, and I just want to start by acknowledging and thanking everyone in the community who the well wishes and the support during my illness and recovery, and especially acknowledge Lisa for her leadership. It was really, I felt like I kind of stepped out at a really challenging time to step away, because we had just put the shelter in place in order. We were monitoring very carefully what might happen. And then I developed the illness, and it was just so reassuring to be able to just completely relax and rest, knowing that we were all in such good hands. As I step back, I mean, I think one of the things that I've observed and felt so relieved to find is that the intent of the shelter in place that we enacted that mid-March really was achieved, and it's thanks to the behavior of everyone in this community. Our work in public health is to try and design the best strategy, trying to balance all of the factors, but it really is the community, it's the behavior of everyone that determines the success of that policy. And so it's always a little bit of a, kind of a white knuckle ride to be on the policy end, not knowing whether or not the community is actually going to, how that's going to be, adhered to. And when we see through demonstration that people really did take the shelter in place seriously, and we see a corresponding decrease in disease and death, that's the equation that's going to lead us through the rest of this. So thank you. There was a recent study at UCSF that suggested that the shelter-in-place order saved approximately 44,000 lives among the 17 million or so Bay Area wide that were part of those counties that initiated what was the earliest shelter-in-place in the nation. So I think we can feel confident that we have done well in the first phase of this epidemic. It will be an ongoing challenge, and certainly too early to celebrate. We have a lot of, it's still an uphill battle, unfortunately. But I think we've demonstrated that we have what it takes. I think the two biggest priorities, every week there will be different priorities, and we'll share them with you. Lisa and I have, determined the highest priorities for this week are two things. One is the focusing on skilled nursing facilities, high-risk settings, and other congregate living facilities where we know that we need to be really very aggressive in terms of preventing outbreaks, and then early detection of any activity and on-site mitigation so that we can limit spread within those facilities. It's something that's becoming more and more clear nationally and in the state. There's a particular vulnerability, a sort of a double vulnerability, especially for our senior sites, because they have high risk for outbreaks because people are gathered closely together, especially when it's challenging to control people's behaviors. If it's a memory ward, or there may be people that have behavioral issues or dementia, which are common in those settings, it's very difficult to practice social distancing effectively. So the risk of transmission can be higher. And at the same time, they're also a population that is at higher risk of bad outcomes should they become ill, including mortality. And we see that in our own numbers here in Marin. I think half of our deaths have come out of infections that were acquired in those sorts of facilities. So super high priority for us this week. And I think later Lisa can go over kind of the strategy that we've adopted she spent the better part of today working with partners in our healthcare system at one of just to make sure that we're responding quickly. That's one priority. The next priority is an obvious one, which is our shelter-in-place order expires on May 3rd. And the obvious question is what comes next? And I'm working very closely with health officers across the region, those same 6 counties, 7 jurisdictions, including the city of Berkeley, who authored the first shelter-in-place order, to design a common agenda for the next shelter-in-place that balances what we know to be the pain and the ongoing harm associated with all of the things that we're not able to do, especially economically and education. I mean, there's a clear recognition that it is difficult for all of us to maintain this level of shutdown societally. However necessary it has been to control this first phase of the epidemic. And those are challenges to balance as we consider reopening. And that's been probably the majority of the work that I've been doing over the past week and this week has been working with experts and other leaders across the region to fashion a shelter-in-place order that balances those challenges. So I think I'll end there, and then we can get into some of the details behind each of those priorities through questions.
That's great. That's great. And before we dive into questions, I understand for those of you that are watching online, we are having some video issues, although it sounds like audio is still going strong. We want to apologize for the glitches that you're experiencing on your end. Do know that we are recording this webinar and we will post it to both our Facebook page and our YouTube page first thing tomorrow morning. So you'll have the opportunity to see the raw video in much better quality than unfortunately you're experiencing right now. So again, our apologies for the glitches that you're experiencing, but we will have this video in its entirety for you first thing tomorrow morning. So for those of you that are just tuning in, this is our community conversation event hosted by the County of Marin and Marin Health and Human Services. And we're joined with Dr. Matt Willis and Dr. Lisa Santora, our public health officers, to talk about COVID-19, our current shelter in place, and our next steps. So we're going to dive into Q&A now, and I want to take a minute and also thank the more than 150 people who submitted questions in advance of this event about this very topic. Unfortunately, we are not going to be able to get through every single question that was submitted, but we will do our very best to cover the general themes of questions that were submitted. And if you are not able to have your question answered, feel free to reach out to us and we'll try to add some of those answers to our FAQs online. And don't forget, we do have our COVID-19 call center, which is operational Monday through Friday from 9:30 to 12 and 1 to 5. And you can reach that call center by dialing 415-473-7191. So let's go ahead and dive into some of our questions here. And, last week we spoke a bit about hospital surge. And one of the questions that was not asked because we ran out of time had to do around the modeling that is being used by different communities to predict when this hospital surge may take place. Specifically, at one point, the county suggested, based on initial modeling, are we going to see an increase, or rather we could see an increase in cases and hospitalizations in the next 2 to 6 weeks. So where are we at now? Can you elaborate a bit on the modeling or whatever the data it is that you're using, and how that may apply to Marin and when hospital surge may actually happen?
Lisa, do you want to take that?
Sure. This has been a challenge for us. We have more than 5 models that are available across the world, and we have been working with our community epidemiology team to evaluate those models to see how they can apply to Marin County. Unfortunately, what we have found in comparing our local data to these models is that they're not an accurate model for predicting either surge or hospitalizations or intensive care use. Part of that is because we have been successful at flattening the curve. So we're not seeing the typical epidemic curve that you would have in other communities that haven't sheltered in place. Another challenge for us is the decision to end the shelter in place. One of the outcomes will be increasing cases, increasing hospitalizations, and unfortunately increasing deaths. And our models do not provide the opportunity to model out where the end of shelter in place happens and then future surges or spikes in COVID-19 cases.
Yeah, thank you. I can add to that. One of obviously the shelter in place has successfully flattened the curve. And almost all the models that we were looking at showed that we would have seen surges that just didn't happen, which is excellent news. And that's sort of the definition of success thus far. What that also means, though, from the point of view of our level of immunity of all of us together as a community, is that we remain largely susceptible. When you prevent infection, you prevent immunity. And so, we would estimate right now, and it's difficult to know, but probably between 95 and 97% of our community is still susceptible. And so that's part of the challenge that I articulated earlier in terms of what we're trying to balance as we consider lifting elements of the shelter in place, is recognizing that our community is, in most intents and purposes, is very similar to the way it was in December before COVID-19 even hit, in terms of our susceptibility across the board, because we have so effectively limited infections. And so the possibility of a second surge is significant. And so we can feel reassured that we didn't see the surges that had been anticipated prior to the shelter in place, and that the modeling had anticipated. But we should not be falsely reassured, and we need to recognize that we are still at significant risk for what some might call a second surge. I think for us, it would really be the first actual surge.
Okay. Well, with that, talking about, that shelter in place and potentially needing to keep an eye on surge before we can lift it, it's been interesting. There's a number of different criteria that have been proposed. So the White House has proposed its Opening Up America Again criteria, which is a 3-phased approach for how a community may loosen a shelter-in-place order to return to some sense of normalcy. Last week, Governor Newsom also outlined a 6-point criteria that he said must be achieved in order to loosen the shelter-in-place. So looking at that, what are those trigger points, or more importantly, what's the data or metrics that you are looking at that will help us determine when we might be able to loosen our shelter in place order in some way? Is it just the hospital surge data, or are there other key points that we should be considering?
Yes, there are other key points beyond the hospital surge data, which is obviously also important. I think the simplest way to conceptualize this is through sort of 4 pillars. These are the 4 things that we think are the most important elements that have to be in place as we allow for increased social interactions that we know increase risk of transmission of disease through lifting certain elements of the shelter in place. The first is the ability to test symptomatic individuals. We're not talking about the ability to test everyone in the county, but we really do need the ability to test early in the course of an illness anyone who becomes symptomatic. So A, testing, and then B, have the workforce in place, the contact investigation that results from those positive tests, so that we can intervene very early. When someone gets a positive result, reach out right away to make sure that person is quarantined, that person is isolated. The term is isolation for people who are sick, quarantine for those who are exposed. So isolating the ill and quarantining those that were exposed. So we have to do an interview with each person to determine who may have been exposed. We have to have the infrastructure in place for people who are ill but cannot successfully isolate within their homes necessarily. If they live in a setting where there may be others at risk, such as a congregate living, situation, or just a home where isolation within the home is not possible, having infrastructure where we can actually get that person out in an alternative place for them to be during their period of infectivity. And then reaching out again to follow those who are exposed over a 14-day period. So that takes a lot of public health workforce. And we've fortunately developed a team of 30 individuals here in Marin who can do that work, and may need to expand that depending on what we see in terms of cases. So that's the second pillar. So that's the first pillar, is testing and contact investigation. The second is a monitoring system, which is something we already have in place, but obviously we needed the ability to track what's happening after we make any changes as early as possible to determine if we're seeing surges, so we can make adjustments to our strategy. The third is hospital system surge capacity. So we need to make sure that, and this is all the work that I think was reviewed on Monday at last week's call, all the work that's happening to make sure that we're able to accommodate people who become ill in our hospital systems, making sure we have adequate ventilators, ICU beds, other beds, et cetera. And then finally, that our community, that we all are prepared, that we understand the rules of the game, that we can successfully practice social distancing, that we can do the covering our face, that is the new order, washing our hands frequently, all those things we know that will allow us to conduct our business and travel within the community, if we're as we're allowed to in new ways, as safely as possible to limit transmission. And with those four things, testing, contact investigation, monitoring system in place, hospital system with surge capacity, and that we as a community are prepared, those are the things that we think will allow us to relax some of the elements of the shelter in place.
That's great. And thank you for defining it so clearly, so that we can really know, we can see the target, right? We can hopefully see the light at the end of the tunnel, even though I realize there's a lot of nuance to those four things. I
want to say also that those are not unachievable. Those are conditions that we are very close to meeting presently.
Well, that's really good to hear. And so tell me, I know that we're looking at how our community is prepared and in reducing those opportunities where they increase that risk of transmission. Tell me, how does this mask or face covering order that you just issued this last week, that will go into effect on Wednesday, how does that come into place with all this?
Yeah, I mean, that's really part of that fourth pillar that our community is prepared to be successful in our social distancing practices, each of us. There's been an increasing body of evidence that's emerged. A lot of what we learn is China, we're like, what are we, 4.5 months in collectively in our global experience of COVID-19. So we're also in such a sort of steep learning curve. And we as public health officials really look to the data that's coming out of places that have had this sort of experience just before we have. So the data out of China and Italy and others have shown that the risk of transmission is actually higher than we had thought in people who are pre-symptomatic or asymptomatic. Pre-symptomatic being, these are individuals who become ill, but for a period of about 2 days, we recognize that those people may actually, before they develop symptoms, still be contagious, infectious to others. And then the others, about 25% of people, it seems, from the latest CDC evidence, who are infected with COVID-19 do not have any symptoms and do not develop symptoms. And so we cannot rely on symptoms as a proxy for infectivity the way we had been earlier. And what that means is that in order to protect ourselves and everyone around us, it's prudent to take that very simple step that we can to prevent transmitting any infection or virus that we may have to the environment by covering our face. COVID-19, or the virus that causes COVID-19, is secreted and spread through droplets. And a very effective way to prevent those droplets is just simply covering our face with cloth. And so that's an intervention that I think is going to be a really necessary and important complement to any of the strategies that would allow us to, again, relate more closely and travel more freely within our own community to prevent surges that would otherwise result.
That's great. Thanks for clearing that up.
I think I would want to add one thing. We have seen that we are successful when using masks. We have not had any healthcare acquired transmission of COVID-19 among healthcare workers. And that is the first system or environment that implemented early masking in our hospitals, which I think proves the effectiveness of these masks, and where we have seen delayed use of face covering or mask universally, for example, in some of our residential care facilities, is where we've seen staff to staff transmission. So it's not patient to staff transmission as some people might think. It is the commingling and the interactions between staff when they're not covering their faces that have resulted in these transmissions, as well as transmissions to residents.
Wow, that's a really interesting point. And I think it further reinforces the notion that, whether it's individuals that want, because a number of the questions that were coming in actually this afternoon were, I have someone that is an older adult, whether it's my grandmother or my great uncle or just a very dear family friend, and they're living all by themselves. And, we just want to go visit them. And what's that risk? And I think it helps highlight the importance of just how this disease, or rather this virus, can be spread, but the importance of taking those important precautions like physical distancing and wearing a mask. So very great point for bringing that up. So let's now move back to, you mentioned that first point in the criteria is testing. And so let's talk a little bit about the testing landscape, because I have to say, of all the hundreds of questions that came in, there was a strong trend around testing. People want to understand, are we testing, which I know we are, but what does that testing landscape look like? Who do you intend to test? Can we ramp up testing? Who would like to tackle that question?
I can start, and then Lisa can add. The question of testing needs to be framed, I think, in terms of when we talk about capacity for testing. The real question is, who are we seeking to test? And currently in Marin County, we have the capacity to test everyone who we think needs to be tested from a public health standpoint and epidemiologic standpoint, which are people who are having symptoms. There are many opportunities for people who are having symptoms to be tested in Marin County, one of which is our point of care testing site, our drive-through testing site that is staffed by the county with support of some of our healthcare partners, that is, all day on weekdays. And we've done, 1,500 or so tests total since we started that operation close to a month ago. So there's, and then healthcare providers, Kaiser, Marin Health, other systems, One Medical. There's a variety of different clinical services that offer testing themselves. So we have through, the net through that is increasing daily, over 2,500 tests now countywide. Some of the I think the concerns when people are afraid that we don't have adequate testing capacity are requests for testing for people who may not meet that criteria for testing currently, which is people who may not have symptoms at all or may not have a known exposure. And I just want to talk a little bit about the challenges associated with that concept of testing people who do not have symptoms and have not had a known exposure. One is the reliability of the test in that setting. So we know that the false negative rate, when we think about testing, unfortunately, one of the unfortunate realities of COVID-19 testing, whether it's the PCR test, which is the test we use to actually measure the presence of the virus in your body, or the antibody testing, which is the test to determine whether or not your immune system has mounted a response and developed antibodies. Both of those, the tests themselves, are not great tests. So they do not perform very well, especially with regards to false negatives. And what I mean by that is a test where you may get a negative result, but you actually have the disease or have the infection. False negative rate for the PCR test, the regular test, is about 20%. It seems to be in the most common test. This is the nasal swab test. That false negative rate actually increases for people that don't have symptoms, because what it's looking for is the presence of the virus in your system. The people who don't have symptoms have less virus, tend to be less viremic, and so the false negative rate would be higher than that. So what that means is up to 1 in 4 people who may be infected but are asymptomatic will have a negative test result. So that's important. The other is that if you're testing someone that doesn't have symptoms and hasn't been exposed, the obvious question is, well, how frequently would you do that? You know, if you're just getting tested for peace of mind, that peace of mind may be short-lived because you know how what your status is, assuming the test was accurate, which we can't on that particular day. But what about all the exposures you may have had that you didn't know about during the next day and the following day and the following day? So logically, would you want to get tested a week later, a month later? How frequently would you test if you're just relying on this, idea of a test for the sake of peace of mind? And we certainly don't have the capacity to test every resident, regardless of symptoms, serially on a regular basis. With 260,000 residents in Marin County, we don't have the testing capacity, nor is there really an epidemiological that kind of testing. So I just want to, be clear that we currently do have the capacity in Marin to test mildly symptomatic individuals whose symptoms are consistent with COVID-19. The process there would be reaching out to your medical provider, describing your symptoms. Most medical providers have a relationship with the Department of Health where they can just fill out a form, a referral form. An appointment would be scheduled. They would drive to our drive-through testing site and obtain testing there, or be tested by their own medical provider if that's their provider's process.
Great. So speaking of testing, are we seeing a backlog at all in our testing? There's a rumor floating around that something with our testing capability is constrained. Is there anything
Yeah, I mean, there's testing that happens in different laboratories, right? There's Quest laboratories, private laboratories, LabCorp. There's the public health lab that does testing in Solano. There's a public health lab that does testing in Richmond. Kaiser has its own testing. UCSF does. So each of them have sort of their own kinetics, their different pace, and some of those systems at sometimes, depending on the supply of testing that comes in on any given day, based on the instruments and the chemicals, the reagents they have at the laboratory, they may not be able to actually manage the volume that comes in on that day, just in terms of the throughput in that laboratory. And so there are sometimes delays in terms of in backlogs, as you described, for some of those. But for the public health laboratory testing, our turnaround is about 24 hours. We're generally able to keep up with the tests that we send to our public health labs are done the following day, and then we get the results out the next day.
That's great to hear. Actually, that's really good to hear. So on that note, what's being done to focus on testing our more vulnerable populations, whether that be seniors or underserved communities or homeless or anything like that? Can you provide some clarity on that?
I can jump in on that one. First, just to reassure people, if you are referred by your healthcare provider for mobile testing or field-based testing at our public health testing site, people are now being offered same day or next day appointments, which is very different than when we started our field-based testing site. So really, the entry point for you, if you're concerned and you have mild symptoms, is to contact your healthcare provider. Second, we're seeing our own field-based testing site shift. And over the past week, in partnership with Kaiser Permanente, Marin Health, and Marin Community Clinics, we've been reaching out and doing mobile testing at our congregate living facilities. As we mentioned earlier, just by the nature of these facilities, they're at higher risk for disease transmission because there's more people per density in those facilities. And they're also often more vulnerable because they're an older adult with chronic conditions that have required them to live in an assisted living facility or skilled nursing facility. We also have treatment programs and recovery programs, shelters for persons experiencing homelessness, and those are priorities for us to be able to offer mobile testing to reach out to those most vulnerable populations. And then lastly, we are now partnering with our federally qualified health centers, which are located across the county, from Coastal Health Alliance to Marin City Health and Wellness, Marin Community Clinics, and Ritter Center, to begin developing their capability to do site-based testing, which would increase the geographic availability of testing throughout Marin County.
That's really good to hear, because we did have a lot of questions that popped up as it related to when will we have more testing in West Marin or Novato or Marin City? So very exciting to hear that that's a development already in the works. So one last question as it relates to testing, and this came up again last week as well. Where are we with antibody testing in Marin County?
Yeah, I can answer that. Antibody testing is, obviously will be very valuable to us. Just stepping back, when we are able to test people for the presence of immunity through antibodies, that will help us in many ways. It will be able to, I think in one important way, guide us in terms of who may be able to return to the workforce, knowing that they're relatively protected. Unfortunately, we're sort of surrounded by unknowns when it comes to antibodies. One is, and this is my personal situation, which is I was antibody tested after my infection, and I have the antibodies, long-term protective antibodies. What we still don't know, just from a science standpoint, is what does that actually represent for me in terms of my protection? Am I immune? Am I not immune? Am I partially, and for how long? So that's an important caveat for us, is we still do not know how to interpret the results of antibody testing in terms of the actual physiologic immunity. The second is the tests themselves that I talked about this with the PCR testing, but it's even more true for the antibody testing, is the performance of antibody tests currently is highly suspect. Under the emergency provisions that the FDA allowed for, normally it takes up to years for a given test to actually be tested and certified and retested and validated, so that you're very clear as a physician as to how to interpret the results of a given test. That normal vetting process has been suspended, partly because it takes so long for COVID-19. So there's all these emergency provisions that allow the rapid development of testing technology that is not well validated. And so we are learning right now that the performance of the antibody tests, even that are being performed regionally at Stanford and San Francisco, and even here, is still not, they're just not performing well enough yet to hang our hat on. So they're still in that stage of mostly sort of experimental mode. Some of our healthcare providers have tested all of their physicians for antibody testing. And one of our largest providers found that none of their physicians had any antibodies with the test that they used. And then another test was used in Santa Clara County. It found like some large proportion of their population, like 8% of those tested, were antibody positive. Very high likelihood of false positives on the one side and maybe false negatives on the other. So just as a word of sort of caution for us before we get too excited about antibody testing, I think time needs to pass for us to determine which tests would actually be the most accurate. And then certainly when that technology is known, we would work to make sure that we have those supplies for us in Marin.
All right, thank you for clearing that up for us. So shifting now to that theme of the behavior of COVID-19 in Marin, I'm curious, I've heard some reports. I've not actually seen any studies, but I've heard reports that COVID-19 might be affecting certain demographics differently than others. Of course, you've shared with us the sensitivities for our older adult population, but I'm curious how COVID-19 might be affecting people of color. And are there, I've heard, as I mentioned anecdotally in other communities, that African Americans may be more adversely affected. So is that true? And are you seeing any of those statistics here in Marin County?
I'll jump first on that one. Nationwide, we are seeing disparities in outcomes among communities of color. And unfortunately, that's because every day communities of color are experiencing health disparities in access to care, disparities in the rates of chronic disease like diabetes and asthma, disparities in income. And we've had a racial equity lens on our emergency response since the beginning, knowing that communities of color in Marin will disproportionately experience the effects of COVID-19, both economically due to job loss, as well as to the outcomes of disease. Fortunately, we are beginning to have more information around the racial and ethnic demographics of COVID-19 in Marin County, and we're not seeing the same trends that we are seeing nationally. We have seen parity in how we are testing across our community. So our testing reflects the demographic profile of Marin County, and so it doesn't suggest that we're not equally testing in our community. We also see in our cases, and this is more information is to follow. In the beginning, we weren't consistently collecting data on race and ethnicity. And if we're going to address racial equity in our community, we need to be able to see the differences in race and ethnicity. And so our public health nurses are calling everyone who's been infected with COVID-19 to gather that information, because when you get tested, depending on where you get tested, if you get tested by public health, we'll ask your race and ethnicity. But if you get tested in commercial labs or other sites, it's not a requirement, and it's not a requirement for reporting. But as of this point, in the cases that we have information on, and it's over 130 of those 199 cases, we have 70% of residents with COVID-19 are white, 12% are Asian, and that's a higher than what is our population of Asian Americans in our community. But that's consistent with how the disease transmitted from China and other Asian countries, and our early expectation that we would have westward movement from, or eastward movement, sorry, get my geography straight, from China to California. 17% of those with COVID-19 have had are Hispanic or Latinx, and less than 1% are African American. And with hospitalizations, we see a higher rate, though, of hospitalizations among Asian Americans. So while 55% of white Marin County residents have been hospitalized, those who have been diagnosed with COVID-19, 20% of Asians in Marin County have been hospitalized with COVID-19, and 21% of Latinos or Hispanic members of our community have been hospitalized, and less than 3% for African American community. We are deeply concerned, though, in our communities of color or low-income communities, there's a much higher risk for more rapid transmission of disease. And that's why it's a priority for us to begin working with our federally qualified health centers to increase the testing rate of those individuals who may have barriers to accessing care, including transportation and other financial barriers or fear. And so we're committed to making sure that our rates continue and that we increase our investments in testing in those spaces, knowing the vulnerability, especially in densely populated areas.
That's great. That's excellent to hear. Thank you for clearing that up as it relates to Marin. Now, Dr. Lisa, I know you also mentioned a bit about our work to come alongside these communities that may be adversely affected. And just today, the state released released a report of skilled nursing, or should I say long-term care facilities across the state that are experiencing outbreaks. And one facility on that list is actually located here in Marin. So I'm curious to hear a little bit more about what it is that Marin Public Health is doing with our medical community to support those older adults that are living in those types of residential care facilities.
Since the beginning of this pandemic, we've known that this is a vulnerability in Marin County. We're the oldest county in the Bay Area. We have more than 30% of residents who are over the age of 60, and many of whom are living in congregate facilities, assisted living facilities, and skilled nursing facilities. We began in partnership with Kaiser Permanente and Marin Health to launch teams to deploy to these facilities to provide education and training. Also to be able to deploy, as I mentioned earlier, to provide mobile testing for both staff and residents when we identify that there is an exposure to COVID-19 in those facilities. And I'm happy to say that this week we've shifted from just mobile deployment for testing, which is important. We can't understate how important testing is, but to engage these facilities, their management and staff, in education and training. And that's where I think there is a challenge, because in our hospitals, we employ a lot of healthcare workers, but in skilled nursing facilities, we have a more diverse group of staff, and we have seen staffing shortages before COVID-19 ever happened. And so we are doubling down on our efforts, not only to provide education and training, but also to make sure that they have the personal protective equipment and that we are monitoring those facilities. So that's a commitment we've had since the beginning. It's a commitment we will continue. And we do see this again as the shelter-in-place order lifts and there's more allowable activities. we will anticipate to see more infection in those congregate facilities. So it's an area we will continue to remain vigilant and try to stay ahead of the curve of transmission in these facilities.
Great, great. And I know, there's been a lot of work probably beyond what we have time to talk about. So it is really relieving to hear that we're not just taking a 10,000 foot approach, but we're truly getting into the nooks and crannies of our various communities here in Marin County to tackle the needs there, whether it be residential care facilities or some of our unique communities elsewhere in Marin.
Can I add something to that?
Go ahead. You go first. I'll go second.
I think what the process is referring to is really one of the silver linings of and the lessons of COVID-19, and I think something that will carry forward in everything we do. Hopefully, we've had to become so practical and so oriented towards problem solving together. And it's really highlighted that none of us can do this alone. I mean, individuals and sectors. Public health couldn't do this alone. Our hospitals can't do it alone. We really need to be functioning together in new ways. And it has really prompted, I think, these relationships that have proven to be so vital and so strong across. These systems that maybe historically might have been seen even, as silos or even competitors, in the healthcare market or whatever, are just absolutely one system for the sake of the community as a whole. And it's just been really, I think, inspiring to be a part of that. And that goes for all branches of government have come together here. Our elected officials, everyone is really aligned in a way that is super refreshing. I think if we the virus itself is so challenging in its own nature, and what we're facing is so difficult that if we had additional challenges associated with not working well together, it would be unmanageable. And unfortunately, I think we're seeing precisely the opposite. We're seeing just how well we can do when we come together.
And I was just going to add that I'm beyond thankful for the work of the staff, the management, and the owners of the skilled nursing facilities, assisted living facilities, and other congregate settings. They've taken on a challenge, and they are an unsung hero. I know a lot of healthcare workers and first responders are getting a lot of attention, but the people who are providing care to our community's most vulnerable residents also deserve all the praise, and they come in and out of work with staffing shortages. And again, we're just thankful for their continued commitment to the residents they work with under really difficult circumstances.
That's great. And thank you for.
I got another one on there, which is, we talk about.
Just take it away.
Yeah, sorry. We do talk about our healthcare workers, and your mental image is often sort of the ICU doc or the emergency room doc, and the nurses in the hospitals and stuff. But there's this army of people out there in these residential care facilities and skilled nursing facilities that are not often sort of hidden from that, and should be absolutely embraced in that frame that we offer around the gratitude we're offering healthcare workers, because the work they're doing is in some ways even more challenging.
Okay. Any other last rebuttals on that one? Just kidding. No, thank you for that extra note, especially as it relates to what a frontline worker may be. It's truly a diverse definition, and we are blessed to have so many brave individuals out there caring for those in need. So I'd like to shift back as we start to end toward the end of our live stream, back to that topic of the shelter-in-place order. And I do want to pause for a second and let our online audience know, or first say thank you for hanging with us. We realize that we've had some technical glitches this evening in our online stream, and do want to let you know that we are recording this live stream. So we will post this online as soon as it's available, so that you can hear the first part of our conversation that unfortunately wasn't available due to the glitch. So keep that in mind. So now I'd like to turn back to the shelter in place, and Marin and the Bay Area quarantined at the same time, and we actually quarantined ahead of the rest of the country. I'm curious, does Marin have to stay in that group? Will it have to wait to lift its shelter in place order until those other communities are ready, or is there an advantage to working as a unit?
Yeah, there's certainly an advantage to working as a unit. It's been, I think, one of the great successes. Just even the sort of the national response has been what the Bay Area was able to manage through collaboration. Going back to that March 15th date when the 6 health officers over the 6 counties decided we needed to move together and got our county councils on board and somehow finagled consensus in a short period of time. And it's been very effective. We are a single human ecosystems in a lot of ways. A lot of our people commuting to the city, it really makes sense to have a unified approach. And we're going to continue to work on that unified approach. At the same time, we know that different counties will have different burdens. And if our burden is lower, significantly than other communities, then the way we're intending to draft the new order is that based on indicators of how well we're doing as a community, our own community could move forward more quickly. And so it's a friendly competition between counties to see how well we can do in our behaviors and really make sure that we're doing everything we can to meet those indicators that will allow us to move forward. Things like, obviously we're not going to relax if we're seeing surges in cases in the hospital. And so there's very specific indicators like less than half of the hospital beds occupied by COVID-19 patients. These are metrics that we will be looking to and others to be triggers, if you will, for further relaxations. And we can do those independently as counties. So we can, if we are more successful than other counties, we will be able to move forward more quickly, but we will start at the same place.
And you mentioned some specific indicators or triggers. Are there others besides the number of hospital beds, like you just mentioned? Are there any that you want to spell out, or are those similar to that criteria you mentioned earlier? I mean, it sounds different.
I mean, they're specific and numerical. I mean, things like, and we're still defining them, but the examples would be, no more than, an increase of no more than 10% of our positive cases. So when we look at our total testing versus the percent positive, we track percent positivity as a marker of changes in incidence. And we want to make sure that we're not seeing greater than 50% of our ICU beds being occupied by COVID-19 patients, total hospital beds being occupied, and an increase in cases above a certain percentage based on statistical significance would be another indicator for us that we wouldn't be able to take any further relaxation until we got that back under control.
Okay, that's great to hear. So I think we're going to go ahead and roll just a few minutes over time since we were a little delayed getting started. One question that we've received quite a lot of interest in is access to the outdoors. And given the benefit that the outdoors have on mental health and physical health, is there an opportunity to loosen the restrictions on parks sooner than later in new variations of a shelter in place? Should we see that? Or does that go back to exactly these triggers, these these trigger indicators, thank you, that might keep us in the same situation we're in now?
It's a both and. So the indicators will be obviously very important guides for us. If we're seeing massive surges in cases, we're obviously going to, have to kind of ratchet things back. But there's also the principles we'll be applying to this. And again, no specific decisions have been made regarding any single activity. But I think it may be reassuring to some to know that one of the principles we're applying to this is how safe is it for that activity to be conducted in ways where social distancing is possible. Obviously indoor, outdoor is categorically very different in terms of the ability to maintain social distancing. So, we're looking at outdoor activities and really considering each of those as being probably among the things that are first relaxed. We have a particular challenge in Marin County that when we say we may be reopening our parks, for example, given that we are a regional magnet, given the beauty and the green space of this county, that we want to make sure we're also building protections so that we're not seeing a lot of influx into the county for people trying to take advantage of our natural beauty. And so that's language we're going to have to craft to any liberalization and increase access to the outdoors. It's a high value for all of us.
It is a high value, but no easy call to make there, as you mentioned. Okay, well, one final question, and this one is a bit of a personal one, Dr. Matt. I'm wondering if you'd like to share with our audience, what did you learn from your experience of having the COVID-19 illness that you're bringing back to your work as our public health officer?
Yeah, it was definitely a humbling experience. And again, thanks just for my team for giving me more than 2 weeks just to lay in bed, which is what it took. I think one of the things I learned just firsthand is not to underestimate this virus. I learned, I think that we've been thinking about surge in terms of, and even in this conversation, think about surge in terms of hospitals and ICUs and making sure that we have enough ventilators, et cetera. I sort of realized the obvious, which is that's the tip of the iceberg, and then under that tip is even a larger number of people who are pretty sick, but probably not necessarily sick enough to be in the hospital. And that we're all going to, if we do see surges and increases in cases, informal networks of support for people in our communities who are perhaps, dependent and incapacitated for up to 2 weeks is going to be an important thing for all of us to think about how we can support one another. I know for me, the meals that were left on our doorstep and the cards, went such a long way. My wife is a physician and she was pulled out of work for 2 weeks to care for me and our kids. And so we're also, I think, as employers, going to need to anticipate perhaps, thinking about sick leave in new ways as we anticipate there may be, as we see more incidents, people who are ill for really 2 to 3 weeks is not an uncommon course for COVID-19. And people may be so ill that their spouses may actually need to also be off of work to serve as caregivers. And so that's just another, remembering that we're going to have a lot of incidents that maybe doesn't meet that threshold for surge into the hospitals, but we'll still need a lot of support and care. And then finally, remembering, I think, I obviously didn't want to be away when I got called out. And I was eager to get back every single day. And finally just had to sort of recognize that I wasn't in the driver's seat. This was the virus is what it is, and it was running its course. And my job was to lay low and do less and rest and to do for it to pass without with the least harm. And I think that's kind of where we are as a community. There is no fast forward button here, and we are reacting to what nature is bringing to us. And we can do this. And I think my recovery, I hope, serves as an example that when we do that well, we do come out the other side and can come back to normal and recover together.
Great. Well, we're really, really happy to have you back, and we're thankful that we have great leadership like Dr. Santora to make sure that our response effort to the Marin community didn't miss a beat. So with that, I'm going to go ahead and wrap up tonight's community conversation. Again, I want to extend our apologies to our online audience for the hiccups that we had in our live stream early on. For those of you that are now watching, we are recording the full session, and we will post that online to the Marin County Government's YouTube page, as well as our Facebook page, as soon as the recorded video is available. So check back tomorrow morning. And we do want to remind you that you can get all of the COVID-19 updates for Marin County at the Marin Health and Human Services website, which is available at marinhhs.org/coronavirus for information in English, or marinhhs.org/-es for information in Spanish. Remember, you can visit that website and subscribe to receive our daily status updates by email, or if you'd prefer to receive them by text message, you can subscribe by texting the phrase Marin COVID to 468-311. Thank you again, everyone, for bearing with us and tuning in. We are planning on holding another community conversation an event this next Monday, so stay tuned for details on that. And otherwise, thank you again for tuning in and have a great night. Stay safe out there, everyone.